Sir, it's sharp 5:30, so with all your due permission, can we begin? Sir, am I audible? Hello?
Yes.
Yes, so it's sharp 5:30. With all your due permission, can we begin?
Yeah.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. And he is none other than Dr. K. Suresh, sir. Sir is MD, DIH, DF, FIAP, FIPHA, FISCD, family physician, public health consultant, Bangalore, and visiting professor of practice, KSRDRU, Garak, Karnataka. With the help of sir, we'll be taking a close look on today's topic, which is managing headaches in smaller settings. Excuse me. Now, I would like to hand over the session to sir for his precious talk to begin. Sir, over to you. You can proceed from here.
Thank you, Batul. Friends, today we are trying to discuss one of the commonest ailment, probably more managed from home remedies than coming to the physician. By the time they come to a general practitioner or a specialist, you would have seen that the patients would have tried all possible home remedies and maybe sometimes even some over-the-counter drugs. So the challenge as of today, until 5 years ago, nobody had thought of a common protocol to address this issue when patients come to the smaller setting or an individual practitioner. My presentation today is going to be a little different than routine. I would like to walk you through what happens if a patient comes to the clinician. What should we all know what we are doing now? First thing we do is trying some analgesics or antidepressant or anti-anxiety drugs, depending upon our assessment of the patient. It's only around 2017, there is a common protocol has been proposed. It's still not globally or nationally accepted, but that gives us, particularly the younger generation, as to how to approach the patients with headache. As far as the magnitude of the problem is concerned, a recent study of review of most of the studies globally indicate that in 1 year time, about 52% of the global population would have had at least one episode of headache. Then you can imagine the number. Of these, most common, particularly among the adolescents and adults, is what we call as tension type headache, which contributes up to 1/4 of total cases. And in that particular age group, it may be more than 50%. Then followed by half of that, is migraine, but there are other types. We'll come to that a little later. 4.5% of people are reporting headache for more than 15 days or more every month. So that's a serious group of people who might be a challenge to the practitioner. This same study also says there's hardly 5% of people where there is no history of headache in their entire lifetime. I don't think any one of us belong to that. Most of the developing countries, headache is a common feature, but the simple reason of so many reasons for tension. You have something,
Sir,
there is a
sorry to
tension, you
interrupt.
don't
Your
have something,
slides are not
tension.
moving.
So
Hello?
tension is the key role, plays a key role for a headache episodes.
Sir, sorry to interrupt. Your slides are not moving.
Huh?
Your slides are not moving, sir. Sorry to interrupt. Can you please change your slides?
Okay, slide is not moving.
No, it's not moving, sir. You have to change your slide.
Let me see what is the problem.
Yeah.
Okay,
Now it is moving, sir. Now it is moving.
okay.
Yes, it is moving.
This first slide of mine just tells you what am I trying to do today. My schema of presentation includes what a clinician is doing or what he can do ideally, what we call as an assessment, and followed by investigations if needed. Very rarely they are needed. And most important thing a clinician has to do is first identify what we call as red flags, or is there a need for urgent reference? Because you should not be faulting if there is some big condition. Once you rule out the need for an urgent referral, you will try to classify the headache into primary or secondary headaches. You can see the visuals which says which are the primary ones. These are tension headaches, as I was telling you, contribute to 1/4 of the total. Migraine and what is called as a cluster headache. Secondary headaches are basically because of the underlying pathology. Usually it is sinusitis among adults, refractory errors in children and adolescents, hypertension in elderly people, and trigeminal neuralgia among adults and senior citizens. So we will try to see how we can do that. And there are common types of age specific, because when a patient comes to you, the easiest way we distinguish them is by age and gender. So we look at that. What happens if it is a child or a woman or a pregnant woman, senior citizen or an adult? How do you proceed? While we do give them an immediate relief by some analgesics, we also have the moral duty to authorize them for home management. Of course, the treatment should be as short as possible, as early as possible, because some of the drugs we are using may be habit forming. As a passing mention, we'll also see what the experts do if you refer. Finally, as a public health person, we would like to look at what is the public health approach. As a country, are we ready to address the national problem of headache? As of today, we do not have any organized effort or a program, but there is definitely a need to address this situation. So how do we approach as an individual doctor or in a small setting? The first thing we do is evaluate and diagnose. History taking becomes most important. All of you do this. There is nothing very specific. What you do is ask them, when did it start? How long has it been there? And how often it happens in a given day, or in a week, or a month. Then one would like also to assess what are the triggers. We know all the headaches are triggered by certain food items, certain situation the individual is facing, physical activities, or some of the medications we are using or not using in full course. We'd also like to take the family history of headache, because some of the headaches like migraine and even some tension headaches are familial in nature. The common mistake we do is we do not take what happens in between two episodes of headache, which are very important to get a better clue of the condition, that is the primary cause, to address it properly. Issues like general weakness, changes in the vision, or periodical loss of consciousness, etc. To understand the seriousness of headache, we would like to see whether it is interfering in the person's day-to-day work, or is it the work that is getting the headache. And then, of course, how much has these episodes of headaches has affected their quality of life. For example, do they feel like spending more time in their bed, sit in a dark room, isolate themselves from the meetings with friends and relatives? So that is the quality of life we need to assess. Then one also looks at the time the headache starts, how it starts, whether it's insidious or instantaneous. Then we inquire about aura before headache. What is an aura? It is an experience that changes the vision or some blind spots, some bright lights, experiences of the numbness and tingling somewhere in the body. Then a long-term effect could be a decrease in appetite and change of the behavior or the individual attitude. Of course, we would take stock of what all has been done so far, any over-the-counter medication, some home-known remedies, like taking a cup of coffee or applying some balm, etc., etc., etc. Then the physical examination as a doctor should include checking for fever, rhinitis, blood pressure, if there is any muscle weakness, balancing problem, vision problems, and any other ear and nose problems. This is common examination. Depending upon the age, for example, if you're talking of adults and senior citizens, you look at blood pressure, sinusitis, balancing problem, particularly among the elderly. So if the person can stand for even 30 seconds on one leg, or can walk, keeping the feet close to each other on a line even for 20 meters, you can find out whether they have a balancing problem or not. So these all will help us to narrow down to the cause of headache. Then, as I told you, we had step 2 involves looking for red flag signs for urgent referral, because we don't want a general practitioner to get into the problem by spending time on details if there is an urgency to refer. Third step involves rule out the possibility of secondary headache by looking into the possibility of refractive errors, sinusitis, or any other infection, ear infection, throat infections, others, You know, all of them have headache. Once we sort it out, then we look at classifying the condition either into primary or secondary causes. Age and gender of the people must be able also be considered. Then we decide the management pathways. Management pathways includes both referral, which comes at the very beginning of your meeting the client, and then treatment pathways when you decide to treat yourself. For example, the first referral pathway is to identify, do they need any quick care at the higher centers? If the signs are not giving any clue, or they are refractory to the treatment which you have been given for, let us say, for about a week's time. So we need to get ourselves trained to identify these red flags and the types of headache which need correct diagnosis. We'll come to that in the next slide. Right now, the entire health system, both in private and public sector, do not have enough trained human resource for appropriate diagnosis and treatment technologies. Medicines are accessible, but which one to choose is very, very discreet. For treating the primary care, we look at basically 4 or 5 common categories. Starts with migraine. Basically, you look at using NSAID, ergot, triptans for an immediate relief as you investigate and try to do certain long-term actions. It has to go simultaneously in identifying the triggers, avoiding the triggers, and over the time, reducing the drug taken. Similarly, tension headache, more to address their anxiety, depression, tension. But anyway, they also need to be temporarily benefited by the analgesics of choice. The cluster headaches usually respond to either subcutaneous or intranasal triptan. Similarly, trigeminal neuralgia and shingles, these are all, which we'll come to that again, respond to subcutaneous triptan injections. And if there is any indication of management of overuse or abuse of drugs, we need to look at gradual withdrawal or use of barbiturates, etc. Now, this is the standard approach. Next 2-3 slides talk of what we call as protocols. First thing when we look at is, as we told, focus, history, and physical examination, as we already gone through. That should help us to classify whether the headache is secondary. And if it is secondary, you need to look at if there is an urgent referral required to a neurologist or some other person. If not, you treat yourself. We'll again go into another slide later, but primary headaches, like which we already mentioned, migraine, tension type, cluster headaches, and medication, can be managed based on the next slide we are coming to. Now, this is, I am sure this is very difficult to follow these slides because the size is small. But I would like to spend more time on this slide, which gives you the entire approach, which is being proposed globally now to be followed by primary care doctors. Here, the first step is to identify it is secondary. There again, when you say secondary, that means there is some serious reason. In that case, you need to identify what are called as red flags or possible indicators of secondary headache. This is done by onset details, whether it is sudden headache, when does it peak, is it onset is insidious, but is slowly progressing, or new onset after the age of 50 years. Second, we look at the clinical characteristics, if there is any associated vomiting, nocturnal only nighttime headache or morning headache, whether the headache is particular areas indicating certain cranial nerve involvement or recent change in characteristic of the headache. We also look at associated features. Could be like malignancy, HIV, of late, COVID-19, and the recent outbreaks of H3N2 or H3N1. We may look at additional clues for secondary headache. That means any headache which is not likely to be primary headache, there is a prolonged aura as a symptom. When the neck examination, you may find a little resistance, which may suggest subtle viral encephalitis or meningitis, and tenderness over some joint or aggravation on chewing. If any of these are yes, what we need is, it indicates emergency and we need to refer, do not indulge unless you are equipped yourself fully. Now, having ruled out that, there are certain secondary things you can do address yourself. For example, if it is a child, suspicion of refractory errors using a Snellen's chart, the corrective measures can be addressed locally by refractive errors. Similarly, sinusitis, which is the commonest problem, again, postnatal drip, foul-smelling nasal discharge, if any, tenderness over the antrums are indicative, and an initial management with antibiotics might help. Or you may have a local ENT surgeon doing what we call as antrum wash. Now, if we have ruled out that there is no secondary, the headache is not secondary, then we look at possible diagnosis of migraine, ETH, trigeminal neuralgia, and other primary headaches, or medication overuse. Migraine, as we all know, is usually moderate to severe intensity, lasts anywhere between 4 hours to 3 days. It is pulsatile headache. They may have more than or equal to 2 of the following signs: nausea or vomiting, photophobia and phonophobia. Photophobia is getting scared of light. Phonophobia is getting scared of your voice. Aggravation by routine physical activities, at least 5 such episodes in the recent past. If this is one of the two of these conditions fulfilled, we diagnose it as migraine and manage with medication, which are generally, you may start with NSAIDs or triptans or ergots, depending upon your personal experience. Look at overuse of medication so that people do not keep taking these tablets. Should not be taken more than 6 hours. In the migraine, what is important is starting the headache as soon as possible when the patient gets the initial symptoms instead of delaying it, and can stop once the headache stops. And prophylactic medication, if headache is there for more than 4 days per month, and acute medications are ineffective, behavioral and lifestyle modifications, stress management, which will come later, will also be helpful in the long run. Tension type headaches are more common among the adolescents, adults, because of various types of headaches, which is tensions. If they are students, it is related to scholastic performance, competition among the friends. Somebody is ridiculing for various, what we call as body shaping. School teacher or a particular subject may not be interesting, that create tension. A particular teacher, because he or she abuses or punishes badly, all these may lead to tension headache. Usually such headaches are mild to moderate. They are non-pulsatile type. It is always bilateral. The person feels as if it is pressing or tightening. There is unlikely to be nausea or vomiting, not aggravated by any of the routine activities, and may have at least 10 such episodes before they reach you. In the management for tension headache, you look at immediately for medications. Avoid if there are medications being overused, and look at the situations which trigger the headache and try to see how that can be addressed. Long-term behavior and lifestyle modification. Trigeminal autonomic cephalalgia, commonly known as trigeminal neuralgia, is a severe side-locked single or multiple episodes in a day, or it could be continuous also. It is usually of a brief duration of less than 3 hours. Restlessness, it is ipsilateral cranial autonomic symptoms, which include redness of the eyes, lacrimation, nasal stuffiness, oral fullness, forehead swelling, etc., and ptosis. The management basically use medication of, as I told you, intranasal or subcutaneous triptan. Prophylactic medications are advised usually. It may need reference to the subspecialist at some point of time. In the same category comes the shingles, which is a chickenpox-like virus. Nowadays, we are seeing cases among the elderly people after the age of 50 years. It's a very painful condition. If it affects the cervical nerve, then you may have severe headache apart from the rashes. Other common primary headaches usually are rare, but they may not be amenable to general practice. You may have to think of referring them. Medical overuse or medication overuse need to be handled by either slowly withdrawing or using some sedatives. Education of the patient becomes very important. Effective medication only during severe attacks. If he or she is on opioids, combined with analgesics, barbiturate, and even combining with coffee, gets better results. Abrupt withdrawal must be avoided. This is yet another chart, basically indicates a similar approach of looking at red flags, possible indicators for the secondary headache, and if none of them are treated at your end, this particular chart classifies only migraine and the tension type headaches to be addressed. So we'll not go into details because this is a repetition of the same. There are certain uncommon headache syndromes, which are frequent headaches. There is a severity relief only for short, less than 3 hours per attack. They are usually unilateral, and there could be associated with loss of consciousness or cognitive behavioral issues. So here, we need to look at the primary cause and may need a referral. Now, this is one, though rare, can be managed at the primary care if we have the first willingness to address. Where viral infections are there, in some of the districts in the country, we have lots of viruses circulating. So viral encephalitis, over a period of 4 weeks, you can see the first day the case presents more as a headache only. Subsequently, there may be some neck rigidity or stroke-like symptoms. And in such cases, having ruled out the possibility of secondary other causes, if possible, do not attempt, just go by the physical examination, which is indicative of neck rigidity, and it may also lead to other issues like hypoglycemia, or person who is known to have migraine likely to be confused. So what we do here is, since these are mild headaches for duration, not acute enough, one can try antivirals. If possible, one can do lumbar puncture, which will indicate the viral infection. That means there is no bacterial infections. Then an empirical treatment will definitely help in treatment of antivirals for a period of about 10 days. If you are already in a district headquarters where there is a possibility of CT scan, they will give you a better clue. Admission to the hospital or observation ward may be done based on the need for initial few days. So therefore, this is one condition which may look serious, but can be managed at the primary care also. Now in this slide, I'm trying to compare the common problems which you may face with clients being brought, conscious or unconscious, complaining of headache. What are those common 5 conditions? You look at headaches which are due to the exposure to high light or voltage, migraine, arterial hypertension, ischemic stroke, and low blood pressure. Now, first thing is you look at the localization of the complaint of headache. In the over voltage, it is entire head. In the migraine, it is basically forehead. In the arterial hypertension, it is the occipital region. In the ischemic stroke, you see in one particular side, right or left. And if it is hypertension, it is what we call in the area of crown, that is at the top of the head. The nature of the pain is usually in the first, it is gradually increasing and squeezing. In migraine, as we told already, it is pulsating and increasing. In the arterial hypertension, it is a pressing pain. In ischemic stroke, it is acute and growing. And low blood pressure is pressing pain. Intensity in the over voltage, it is usually small pain. Whenever he or she says, I see bright light, I get headache. Migraine, as we all know, is a very severe pain. Similarly, arterial hypertension and ischemic stroke. And the low blood pressure is a small, dull headache. Duration is usually from half an hour to 1 week in case of over voltage, whereas migraine could be several hours to days. The entire period of increased pressure, arterial hypertension, depends upon the mental pressure the person has. And ischemic is continued. Similarly, low blood pressure is constant pain. What are the other possibility of the accompaniments? In the over voltage, as I told you, the person is scared of either light or sound, both in migraine and voltage. In arterial hypertension, they are more worried about the noise in the ears, dizziness, nausea, vision blurring. Ischemic stroke also one sees there is a problem in vision, movement, memory, speech, and in low blood pressure, it is dizziness, tinnitus, fatigue, and drowsiness. So based on this, the treatments, one can look at a common chart here. We have already talked of this. I will not go into this chart particularly. This addresses, based on the level of care, what all can be done. I think as a smaller setting and as a general practitioner, one can go up to secondary level care, where except the tertiary level, which is basically involvement of neurological causes, rest of them can be managed at your level. Now, we are looking at the situation of headaches in general. First, we look at the categories of adult population. This, as I told you, is extremely common. They occur repeatedly. And generally, we call them headache disorder. The most common cause is tension type, we already told you. What is called an episodic tension type is usually for less than 15 days per month, and nearly 70% of the population report such headache. Stress is the common trigger here. Some or the other, whether family stress, occupational stress, educational stress, various types of stress, financial, etc., etc. And these tension headaches are more common in men than men, for the obvious reason that these women are generally more get disturbed with whatever changes happen in their life. The proportion is stated to be 3:1. Usually, the tension types are based on whether it is anxiety, constantly worrying nature people, and some people cannot control the anxiety that precipitates headaches. Usually, these headaches are triggered like lifestyle factors like consumption of alcohol, either more or withdrawal, usually red wine. Some people get by eating processed meat because it contains nitrates. Changes in the sleep pattern, because if you have to do night duty or you are traveling overnight, next day you may feel a headache. Lack of adequate sleep, since we are talking of adult, a minimum of 7 to 8 hours sleep, if it is not there, it might result in a headache next. Most important of this becoming is the posture, because most of the people work on their laptop, desktop, constantly getting their headache, vision, and using mobile, particularly in darkness, and common issues like missing the meal or stress due to anything. The global burden was estimated about 6 years ago. It says that about 4.5 crore people have migraine, whereas nearly 7.5 crore people, 7 million, that is 70 lakh people, have tension type headache. As far as India is concerned, we have a limited data, not very scientifically done. We will quote you later in the later slide. But they also support a similar trend. The major challenges addressing these disorders are generally people do not perceive it as severe. We do not know what is the actual burden. There is no standard protocol for management. And the neurological disorders approach is low in developing countries like India. There is a common nature because of the postures we use. Most of the generation which are looking either at the computers or mobiles, which is a part, most of us spend anywhere between 3 hours to 10 hours per day looking at the screens. And it is estimated, these are called as cervicogenic headache, that is due to the cervical vertebral column bending, etc., etc. We'll come to that. Currently, it is expected that 1/4 of secondary headaches are due to the cervical regional disposition, spine. They are defined as a pain referred from a source in the neck and perceived in one or more regions in the head or on the face. So it is not necessarily only head, sometimes face, because it all starts with in the neck. 4% of the total population, exact cause is unclear. What is demonstrated is there is a connection between nerves, particularly trigeminal nerve and cranial nerves, cranial nerve number 5, face and head. These spinal nerves are the first 3 vertebrae, which called trigeminal cervical junction. So the positional default in these vertebrae is likely to be the cause of cervicogenic headache. Upright position in the human results a vertical gravitational compression, as we all know. Over time, when these vertebrae start degenerating, there will be a pressure on the nerves, which might result in abnormal muscle tone, that affect the positional relationship and cause cervical motion pattern, that is the movement. So currently there is a study going on to see what cervical pathology may result for this and how that can be addressed. As of now, it is still a mystery. One such case of a male person, for an example, we are quoting here, a 37-year-old male approached for a persistent headache, which subsided after eating something, but was later admitted with stroke-like symptoms. The lumbar puncture suggested viral etiology, as the CSF did not yield any specific virus or bacteria. Patient CT was done, it was non-diagnostic. MRI was also done, which confirmed an intracranial tension, and EEG showed no definite epileptic form discharges. Here, this is what I was telling you about the viral encephalitis. The person was put on an intravenous acyclovir, 800 mg, for 10 days, and followed for another 10 days with oral acyclovir that resolved the solution completely. Therefore, this is one thing which up to secondary level people can manage at your end. This is a unique case, as postprandial resolution of the patient headache with no evidence of specific virus. So an insidious causes of headache may be addressed suspecting before you think of referring to a neurologist. Headache in children is another thing. Most children come, particularly adolescents. The keenness here is among younger children, the headache is only about 25% of the younger children get, whereas it is the reverse. In adolescents, it becomes 75%. Children in the age group of 5 to 17 years, in one of the study reported, 20% of them are reported headache and 15% were tensional type, basically because of the school performances. And among the adults, it is more of finding work, college studies, etc., etc. And 5% reported migraines. Basically, this was girls. Usually in children, the headache does not last much. One most significant thing is children complain abdominal pain and vomiting and nausea, along with headache or even without headache. So one needs to be careful whenever a child talks of tummy pain. All types of illness, infections we know will cause sinus infection, ear infections, head trauma if children fall down, and encephalitis, meningitis. The red flags in children should be increase in frequency, weakness, loss of sensation, headache as soon as they get up, with or without vomiting, confusion or difficulty in thinking. So they may lead to visual changes, two common kinds of headache that are seen in kids, I told you, are tension type and headache. Of late, refractive errors are becoming more common. I have seen in the last week itself 3 children complaining of headache, and on examination of high myopia in the range of -3 to -5. So rule out ear infections, refractive errors before you attempt addressing them. Their examination is typical. Basically, child may not be able to complain, but we need to get the queries answered by the parents or anybody who is accompanying the child. These again, apart from migraine and tension headache, children get acute, what is called as acute headache symptom, and it does not last long. Usually it is throbbing in nature, and the moment they go and join in friends, they may get relief. Acute recurrent headaches sometimes also could be even without migraine. Such children may have pallor, stomach upset, sensitive to either smell or taste. So we need to look at if any triggering factor. The treatment basically involves initially with medication, headache education, that is identifying the triggers which results in the headache for the child. Lifestyle changes in the long run, which includes a minimum of 8 hours sleep every night, drinking about a glass or 250 ml of water 6 times a day, 3 healthy meals, outdoor games or cardio exercises, and relaxation. Stress management by deep breathing exercises, mindfulness, mental imagery, relaxation, musical therapy, counseling, and spending time with your friends. Special recommendation for children would be looking, as I told you, the ophthalmic ENT causes. Sometimes a gastroenterologist may be needed and a psychiatrist suggestion may be required. So you can see the philosophy, how the stress affects. Stress basically leads to increased peripheral activation or sensitization. It reduces pain detection threshold and increases intensity for noxious signal, which myofascial result to CNS sensitivity and results in headache. Sometimes it may diffuse noxious inhibitory control that results to sensitivity, and the child may just wind up and sit alone. Now, the use of drugs in such cases, as a recent study says, giving only acetaminophen, that is your routine analgesics, in the middle row, and along with coffee or a form of caffeine, either tea or coffee, have better results than tablet alone. Placebo also sometimes helps. So you can try the combination of drugs better than single one. Coming to the geriatric headaches, here the common thing one to note is the proportion of senior citizens having headaches comes down slowly after the age of 75. The prevalence drops from 55% in women to 21% in men from what it was around 75%. Here the common causes are cerebrovascular disease, head trauma, temporal arteritis, trigeminal neuralgia, what is called as post-herpetic neuralgia. I was telling you shingles. And another condition which is known as hypnic headache is common between the age of 40 and 80 years. You can rule out by drug withdrawal and all earlier conditions you rule out. So headache, unless there is a cardiovascular problem or head trauma, in general, primary headaches in senior citizens are less common other than their nerve infections. One common or specific category is women, how you manage women with headache. Headache is very common in the first trimester of pregnancy, particularly women who are already prone to headaches. The first trimester pregnancy poses much larger problem. Because there are hormonal changes and the way the blood circulation changes, the causes include basically people taking tea or coffee once they are pregnant, general fatigue basically due to anemia, sinus congestion, blood pressure in general or due to preeclampsia, stress and hunger, too much of dehydration, exposure to sun, and as I told you, preeclamptic condition. People who have migraine are seen to have two changes when they become pregnant. Some of them get relieved of the migraine, some it gets accelerated. So you need to consider both possibilities. The management, paracetamol is the only drug that can be tried safely. The other drugs like aspirin and ibuprofen are not recommended. A compression usually helps. A warm compression around the eyes and nose if for sinusitis, and a cold compress for the tension type headache. Steam inhalation is another thing which helps stuffy nose and the subsequent headache. Avoiding sunlight, using umbrella when they are in hot sun. General home household treatment like a massage, taking small food, helping frequently, staying active, getting the eyes tested, and taking a shower itself or watering your face with cold splash of water helps. There are other yoga, pranayama, etc. which are recommended. Overall global burden, we have discussed, this is only for an academic interest. The last 3 slides are only for academic purpose, which I will not go into details because individually we have covered all of these. Now, this is one recent study in Delhi which says the 1-year prevalence was around 27%. And based on this 1-year prevalence, tension type headache and migraines, chronic headaches in India are estimated to be migraine about 21 crores, tension type headaches 30 crores, and chronic daily headache about 2.5 crores on any given day. We have a similar type of study done both in Calcutta and Karnataka, giving a similar indication. I will not go into those details. Again, basically, these are more common in female than men. Temporal tension type of headaches contribute larger proportion, followed by migraine. Treatment patterns we already looked at, and this is basically some condition which we already talked, so I will not go again. So if you have to look at common as a practitioner, first look at migraine, think of migraine, try to rule out migraine. Then go for the tension headache. Look at cluster headache, and if it is a lady, be careful about hormonal headaches, where around the menstrual periods, people get headache. 70% of the women may have a headache. They occur before, during, or immediately after the period. Some of the people who are using oral contraceptives, either for postponing pregnancy or preventing pregnancy, may also complain of headache. The management depends upon withdrawal, removing or not using the drugs. So these are basically a theoretical way how you classify and what are the common drugs used in all the global burden. We have already considered. I will not get into the details. This one slide summarizes the type of headaches, migraine, sinusitis, school children because of the refractive errors, and tension type headache, temporal headache, migraine, cluster headache. Using phones in dark is one of the recent development. So this classifies all other headaches. From the public health point of view, it is suffice to say that we do not have any standard protocol globally. What is proposed is only in the recent past 5 years. It needs to be tested and to be finally agreed upon. With this, the summary talks of all the conditions which we talk. Basically, the management trick is immediate management of pain, then addressing the triggers, lifestyle changes. Way forward, as a country, we need to have a program for this, which we do not. Basically, we need to develop, instead of waiting for the best, an algorithm which I represented with help will be a good for many, though it may not be best for few. There is a significant disability attack because we lose a lot of working days among the working population, and the students miss schools and colleges. Therefore, we plead for a national program to address the situation. With this, I open the discussion for any questions. These are some references used in this presentation. Thank you. Can you take over?
Thank you so much, sir, for your comprehensive talk and for sharing such wonderful insights upon the platform with all your enriching experience and the information that you have shared in. We have received few questions. I would like to put it across to you. The first question is, when the whole family complains of headaches, what specific cause of headache should be checked for?
As I told you, migraine one is the commonest of the family headache runnings in family. Second, of late we have observed use of digital equipment. Few years ago, not long, only 5 years ago, we used to advise that people should get exposed to the screens, be it TV or mobile phone, not more than 2 to 3 hours. Today, 2 to 3 hours is nothing. People get exposed at least for 10 hours. And the worst thing is children, particularly adolescents, using mobiles in dark. I showed you one of the picture where a girl is covering with the blanket and then trying to do something on the mobile. Third other cause is the tension type headache. Among all grown-up people of a family is common when there are financial constraints, or because the family does not have a source of income. Headache is not restricted to only head of the family, but it might bother everybody. So these are the 3 top conditions where one need to give an address if the majority of the family members are suffering. Next.
Thank you so much, sir, for answering this question. We will move to the next question that we have received. And this question is, what is the best non-drug cure for migraines?
What is the best?
Non-drug cure for migraines.
Non-drug cure migraine. Basically, as we were telling, tension increases the episodes of mention one. Second, avoiding overeating at a single meal. And then cold compressions are the best one, which are among the non-medication approaches.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And this question is, are migraines hereditary?
We can't call it genetic, but it is runs in families, no doubt. Nearly about 2/3 of migraines are running in families. There are very few persons who says nobody else in the family is suffering from migraine. It may not be immediate parents, but yes, if you trace 3 generations, you will find the history of familial migraine.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the last question for today's session, what are the risk factors for stroke in patients with migraine headache?
Can you repeat the question?
The question is, what are the risk factors for stroke in patients with migraine headache?
No, I'm still not getting after the risk factors. Can you read again?
What are the risk factors for stroke in patients with migraine headache?
No, I'm still not getting that word. After you were saying risk factor, after risk factor, what is the word?
Factors for stroke, sir. Stroke.
Huh? Stroke.
For stroke, yes, yes. For stroke in patients.
No, neurological causes and hypertension. These are 2 major conditions which will exaggerate the migraine. And sometimes there is a confusion between whether it is hypertension or migraine. So as we already seen in elderly people, the cerebrovascular episodes are more common in the aged people. The youngsters, it may not be an issue. Therefore, when you see an elderly patient complaining of headache, the priority, as I showed in the list, should be looked at the cerebrovascular situation, basically hypertension, particularly arterial hypertension. And there is another issue of what we call as postural hypotension. Blood pressure monitoring usually done in one position, but for elderly, it is always better to monitor the blood pressure in 3 positions, lying down, sitting, and standing up. So there you will see the gap of anything more than 6 units between one position and another position, either systolic or diastolic. You need to suspect some cerebrovascular problems and get it fully investigated.
Thank you so much, sir. Thank you for your comprehensive talk and for answering all the questions. That was the last question for today's session. And with this, I would also like to thank all the viewers who have joined our platform for this interactive session and for such an important topic that you have shared in, sir. Thank you so much for your wonderful insights.
Thank you, Batu. We'll go off the line. Thank you.
Thank you so much, sir. Thank you. Have a good day.